Just ahead on this week's edition of Being Well, my guest is Dr. Greg Babcock, interventional radiologist from Carl. We'll learn more about the types of procedures that are performed by interventional radiologists, specifically how uterine fibroid tumors can be treated. That's next, so stay right here. Well, Dr. Babcock, thanks for coming on Being Well for the first time. We're happy to have you here.
Oh, thank you. I'm glad to be here.
You are an interventional radiologist.
Yes, I am.
Tell us a little bit about what that means and what your job entails.
Interventional radiology is otherwise known as minimally invasive surgery or even image-guided surgery. What we do is we get access to places that otherwise you'd have to have a full open surgery to have the procedure done. Generally, we can do anything from abscess drainages, where we can go in percutaneous with an incision about this big, and we can put catheters and things in just little hollow tubes and get the bad stuff out where a person doesn't have to go back into surgery or go into surgery at all sometimes. This helps with people with like ruptured appendicitis and other things. We also do peripheral vascular disease. We treat cancer, and we also help people with liver failure, and a lot of it is just small incisions, and then we go in with our catheters, and we can perform everything kind of like microsurgery through these little access windows that we create. A lot of people know about like coronary artery angioplasty and stenting. It was interventional radiology that actually first developed that process. And since then, we've given it over, and cardiology is just run with it. And look at all the things that they're doing now. We still pretty much treat everywhere else except for the brain and the heart with any type of arterial disease. And we also help with people with renal failure and getting dialysis and access for them. And we do a lot of cancer treatments for people that have disease in the liver. It's pretty much where we're focused right now. But they're trying to branch out in other places where they're doing prostate or people with pancreatic cancer.
Okay. Well, one of the ways that interventional radiology is helpful is for women who suffer from uterine fibroid tumors.
That's right.
Let's talk a little bit about what they are and how do women develop them and why.
Okay. Well, depending on what you read, at least 50% of all women will generally get a fibroid of some size or shape. But generally they can go about their lives and not know it. All it is it's a benign tumor, and all it takes is one cell to be a little bit abnormal, and it's smooth muscle and fibrous connective tissue, and it just gets a little haywire and keeps growing and growing. They call them pseudo-encapsulated. Basically, these things just start off and then they grow, and then they compress the tissue around them. And if they grow big enough, or if they're in the wrong place, that's when they start creating problems. And people can have multiple fibroids. They could just have one. Generally, you won't get a fibroid until sometime after you start your menstrual cycle. It's almost unheard of to have it before you start PMS. And generally, most of the women that have them that are symptomatic are usually in their 30s and 40s. Although we'll occasionally get some people that are in their 20s, but most of them in the 30s, 40s, or even up into 50s. And natural history is they continue to grow, and their blood supply is on the outside. So as they get bigger, they kind of outgrow their blood supply. So the inside portion, the smaller portion inside, starts dying because it can't actually get the blood and the nutrients it needs. And over time, a lot of them will just involute and necrose and die off on their own. But sometimes patients can't wait that long because their symptoms are so severe. Everybody can get them if you have a uterus and estrogen. So they really don't know why they grow, but what they do know is they grow with estrogen and progestin and some of the other hormones and growth factors, but they just don't know why yet.
Are there some risk factors or populations of women that get them more than others?
Yes, there clearly are. It's definitely seen more often in African Americans, and there's been some suggestion that it's also kind of related to keloids, which
Okay.
African Americans, it's a
So what
kind
are
of
what are keloids?
it's kind of an abnormal scar tissue growth.
Okay.
But African Americans definitely get them more often. There's definitely been a strong link with obesity, diabetes, which sometimes diabetes, at least type 2 and obesity kind of go hand in hand, hypertension, and hereditary. If you have a mother and grandmother that have had them, you're definitely more likely to get them.
Oh, go ahead.
Oh, I was going to say, and also null parity. If you've never had any pregnancies,
Okay.
then you're also going to be at an increased risk of getting them.
Okay. Do they only grow in the uterus, or can they grow outside the uterus? Can they grow in the fallopian tubes or on them?
They can grow anywhere where there's uterus, because
Okay.
it's the muscle tissue is what
Okay.
the abnormality is. So they can grow in the cervix, they can grow on the inside. There's actually a couple of subtypes. So there's subserosal, and if you think of it, the uterus as either like a kind of an inverted triangle or even a balloon shaped. They can grow on the outside, right underneath the covering of the uterus, and those are called subserosal. They can grow intramural or within the muscle itself, or they can grow submucosal, which is actually just under the inside layer of the uterus, and those are the ones that can be the most problematic. The fourth type is pedunculated, and these actually grow out on a little stalk, and sometimes they can actually break off, and those can be problematic no matter where they're at. If they're subserosal, they can break off inside the pelvis, and then they can actually, as they're dying, create a really bad infection.
Okay.
And if they're submucosal on the inside, they can cause problems with attachment of the egg for pregnancy, or they can actually cause more problems with bleeding.
Okay. Now, can these types of tumors ever turn cancerous?
There's some debate on that. Right now, what everyone says is yes, they can turn into a sarcomatous or a malignant tumor, and generally it's considered that they're doing it on the inside.
Okay.
But it's less than 1%. I think the number is somewhere between like 0.13 and 0.29% of these are thought to become sarcomatous, but some people don't believe. They think actually that when they find these, it's actually a de novo. It was going to be a cancer no matter what it was.
What are some of the symptoms? I mean, can you have fibroid tumors and not even know it? Not have
Absolutely.
Any symptoms? Okay.
Absolutely. It depends on where. If you have one that's intramural, definitely just within the muscle when it's small, you could go your whole life and never know it. And they find a lot of these in autopsies.
Okay.
You know, she had, a fibroid, and it doesn't cause any consequences.
Okay.
And if you have them and they start getting smaller after, because they stop growing usually at menopause, again, maybe you knew you had them and then they stop. But if they get big enough, you'll start, or they're growing in the wrong place, you'll start having symptoms. One of the biggest symptoms is menorrhagia, or really heavy menstrual bleeding.
Okay.
And people know it. It just all of a sudden there'll be a change, and it's progressive. It'll usually continue on and be very, very heavy. Bleeding in between periods, longer periods, or even more severe periods are also the big ones, the ones that are real noticeable. Some people, if they go on long enough and these things can grow about the size of a softball, and if you have more than one, well, then you can imagine that's volume, that's space that they start filling. People will get bloated. They'll get early satiation. When they're eating, all of a sudden they don't eat as much. They're full. They'll start compressing on the bladder, so they'll start having increased urinary frequency. They have to go potty all the time, and then that's usually a really big complaint. And sometimes it's just the clothing that they can wear.
Really?
Yeah, it's all of a sudden I just feel very bloated all the time, but particularly during their periods, and their sizes of jeans or dresses have gone up, and they just notice I'm big here.
Yeah,
and
so
this
it may
is
not be
abnormal.
you've just put on a bunch of weight. It could actually be something.
Absolutely.
Something else.
Usually by that time they've been followed sequentially with some type of imaging, and usually that's with ultrasound. It's kind of non-invasive. They can just follow it and they track the growth. And then as soon as the symptoms and the fibroids are big enough that we need to do something about it, we already kind of know what's there.
Okay. That was my next question, is how do you diagnose them? There's different imaging techniques. I mean, if you go to your general practitioner with some symptoms, What are some of the ways that they can check to see what's going on?
Physical exam is, generally what they're going to start with, because it's the easiest. You're in the office, they can just do it. Sometimes there'll be compression on the cervix, or they can actually measure fundal height and how big the uterus is. And if you have someone comes in and they're not pregnant, and all of a sudden the uterus seems to be enlarged, well, that usually means something's going on. So then the next test would be some type of imaging.
Okay.
Now, as long as it's related to the menstrual cycle, more than likely, I think somebody would start with an ultrasound. There's no radiation. It's one of the cheaper exams, and it's fairly quick to get in and get out. And most women, are familiar with having ultrasound exams before, especially if they've ever been pregnant.
Okay.
That gives us a pretty good estimation, although not the most accurate, but a pretty good estimation of how many are there, the sizes, and where they are, and the types that they are.
Okay. We're going to talk about treatment options in just a little bit, but this definitely would have an impact on a woman's fertility.
Yes.
If they're bad enough.
It could.
Okay. And why is that?
Well, if you have a pedunculated or submucosal type of fibroid and they were big enough, it could block sperm from actually getting where it needs to go, or it could just create an abnormal environment where the egg can no longer attach to where it needs to attach. It doesn't happen very often, but yes, it definitely can have that problem, or it can even cause spontaneous abortions if it's big enough in there, especially the pedunculated ones, where they're on a stalk and they're causing problems. If a woman has numerous spontaneous abortions, they're going to start investigating. Why is this happening? And then they would generally start with physical exam and ultrasound.
Okay. So a woman is diagnosed with these, she goes to her OB/GYN or her general practitioner, and they determine that something needs to be done. So they'll see someone like you. Well, let's talk about what are some of the methods for getting rid of them?
Okay. You could choose expectant management, where you're doing NSAIDs and things that are doing the bloating, the cramping, if that's your biggest problem. What really becomes problematic is if they start having the real heavy menstrual cycles, and then they're going to have to figure out, well, where are and how many and how big.
Yeah.
Sometimes what they can do is a hysteroscopy, where they can go in there with a camera and they can either cauterize, if it's a pedunculated one, and remove some of that tissue just by going in through the cervical canal. And that's the least invasive, because you don't have to actually make any holes or incisions anywhere. Up from that, you can do a myomectomy, where they're actually going in there and they're kind of removing some of the submucosal. So basically, the myomectomy is a nice thing where they can keep the uterus, so in case you have a patient that still wants to get pregnant, but they can remove the fibroids that are causing the problems.
Okay.
And then it gets more invasive as these things become larger and more problematic. And then it would either be a hysterectomy, and there's a couple of different ways that they can get hysterectomies. You can either do a transvaginal, or they can do surgery with usually laparoscopy. So it's minimally invasive in the sense that it's not quite an open surgery, but it's still a full surgery.
Okay.
And there's a longer recovery time. Or they can come and get a uterine artery embolization.
Okay. What is the method that you perform the most, that you've had the most success with?
What we use, and it's the only method that we actually use for these, is the uterine artery embolization.
Okay.
And what we do is a little incision. We get access to the arteries at the leg. Basically, it's right at that crease where your leg meets your body, and we get into the femoral artery. And because of the pelvis and the symmetry of it, there's a vessel, a uterine artery, on each side. And usually from that one access point, we can access both sides, although occasionally we do need to make another small incision on the other side to get in. And then what we do is we take pictures using video fluoroscopy and contrast, and we inject contrast, and that kind of goes where the blood goes. And it gives us a roadmap of the abnormally enlarged uterine artery, and it shows us the fibroids. And then what we do is we go in with sequentially smaller catheters, and the catheters we generally use are smaller than an ink pen cartridge.
Okay.
And we go in there and we inject very, very small particles. These things look like little BBs made out of plastic. Actually, it's like a PVA material, polyvinyl alcohol. And we inject these under fluoroscopy, and we do it on both sides, and we do it just enough to kind of what they call pruning the tree. If you can imagine, the arteries start off really big and then they just get smaller and smaller and they branch, kind of like a tree. And then what we do is we stop the blood flow by these things clumping up in the vessels that are feeding the fibroids, that are allowing them to grow.
Okay.
And we stop the blood supply to the fibroids, and then they shrink and involute over time. It takes a few months. It's not, I'm fixed. But the nice thing is you avoid surgery. The recovery time is much, much easier. It's usually, for us, it's about a week to 2 weeks. You're only in the hospital usually overnight.
Okay.
Compared to surgery, it could be 3 to 4 weeks or maybe even longer. Although with some of the newer robotic techniques, they've got it down to about 3 weeks, I think.
So how does that process, or how long is that, well, I don't want to call it surgery, that procedure take? If a woman comes in, how long does that usually take you to perform that?
Generally, if it's a straightforward case, we're done in about 2 hours, sometimes 2.5 hours. So it's relatively quick. The patient just lays on our table and they're awake.
I was going to ask, are you under full anesthesia or are they awake?
Yeah, they're awake. But what we do is we put them in what we call kind of a twilight. We have a combination of medications that we give, both Versed and fentanyl, and one takes away the pain and the other one makes sure that they really don't care so much. For the most part, access, when we make a little incision, the lidocaine burns quite a bit for a few seconds and then you're numb. After that, most patients don't feel anything until we're nearly done with the first side of the embolization, and then they'll start feeling some of that cramping, and it's very close to what they felt during their menstrual cycle.
So you're in the hospital that one night and you go home the next day.
Absolutely.
What are some of the side effects, or what kind of things can you experience, the next day after you've been at home? Can you go back to work the next day, or what do you recommend?
Generally, we tell our patients you want to take about a week off.
Okay.
Kind of a week where you're just not going to feel up to it. The first day or two is usually the worst. We keep people in the hospital for pain control. That really is the big thing, because what we're doing is we're starving the fibroids, and that can cause some very severe cramping. So we use narcotics to keep the pain control, and usually that's the first 48 hours that really is the worst. After that, most people get what we call a post-embolic syndrome, or kind of flu-like. Yeah, you don't feel great, but you don't really feel completely bad. There's not really a lot of pain anymore, just a little cramping, but you just have the blahs. Kind of flu-like, maybe even some low-grade temperature, and you just don't feel like doing much. That lasts about 5 days.
Okay.
And then after that, most people after the first week are able to return to work. Some people, they need the 2 weeks, but most people, I would say that they're ready to return to work within the first week.
So when you do that procedure, you're cutting the blood supply off to the tumor.
Yes.
What happens to that tumor?
It slowly dies.
Okay. Does your body dissolve that, or?
It just incorporates it over time. It becomes internal scar tissue, so to speak, but it just will slowly, and then it's so small that it's just no longer problematic, or it's just completely gone.
When you're working on these tumors, what's considered, let's use real objects. What's considered a small tumor, and what's something that's considered large?
I would say anything larger than an orange is large. We've seen them, when we do get them, where people will have one that's an orange size, one that's a softball size. I mean, the last one I did, the woman had one that was about the size of a softball.
Oh my gosh.
And she was actually have a lot of bloating and size changes, related to her fibroids. And she had multiple. She, I think, all told had about 7.
Okay.
But mostly, I think people start feeling some kind of experience of discomfort, or one of the symptoms that we talked about, once it gets about the size of a golf ball.
Okay. How long does it, I don't know if you know, how long does it take for them to grow?
It depends on the person.
Okay.
It depends on how many there are, it depends on the person. A lot of that is just very, very individualistic. Having them, and you have them, most people get them evaluated with ultrasound as follow-ups about once a year.
Okay.
So just they'll come in, they'll have a scheduled appointment, the ultrasound, and then the ultrasound, whoever is going to read that, usually it's one of the radiologists, some of the OB-GYN read the ultrasounds. They'll compare them to the measurements of last time. They'll try and get the same measurements, or this way, and they'll compare them, and then just see if they've grown any, and they can kind of give them an idea of the progress. But generally speaking, you don't need to do anything unless the symptoms are severe enough.
Okay. So once that's been taken care of, can they continue to grow in other places and you can continue to get them, or?
You can, generally speaking, once they've been gotten, they've been gotten. But until menopause, you would still be susceptible to growing some more. I've never seen that.
Okay. All right. Well, we have just a few minutes left. Let's talk about, is there anything that we can do to prevent them, or if you're going to get them, it doesn't really matter what you do?
Mostly you're going to get them if you have a uterus and you have estrogen,
Okay.
like we talked. We really don't know why they grow. We just know that they do. We know that they are responsive to estrogen. What you can do is control your hypertension, control obesity. Those are definitely two things. Control diabetes. That's, these are definitely things that are closely linked. But other than that, there's not really a lot extra that you can do. If you have them and they're symptomatic, there are a few other medications, birth control pills. There is GnRH analogs that they can use. There's danazol. There's a few medications, but all of those come with side effects. Some women, especially if you smoke, whether or not you should be on birth control is questionable, because you're going to be more prone to getting blood clots in the legs. Danazol causes abnormal hair growth, deepening of the voice.
That's not good.
Exactly. So there are medications if people want to avoid procedures altogether. There are definitely some things that they can do to prevent that. But ultimately, if you get them and they become symptomatic enough, it's just a matter of taking care of them. And for some women, getting a hysterectomy, that's okay.
Yeah.
That's okay. There's some risks and complications that are associated with that are a little bit higher than the uterine artery, but they know that their uterus is gone, they don't have to deal with that anymore, and they're done with. But other women, they want to avoid the surgery, or because of work and money issues, they can't take the time off.
Yeah.
And this gives them an opportunity to go another route that's very successful and very comparable with the end results. And I think it's about 80 to 95% of all patients have relief of symptoms within the first 3 months.
Okay. Well, it sounds like there's a lot of options out there for women to choose from. And
Absolutely.
I want to thank you for coming on the show and explaining this topic to us. I learned a lot. I'm hoping our viewers did too. So we look forward to having you back again.
No,